Early stage is really dichotomous from advanced disease. Our major concerns in early stage is proper surgical resection, ideally an R0 resection so that the margins are negative, that the most proximal nodes are clean, that nodes have been sampled. It's amazing in 2013 the number of patients we see who have quote unquote had a surgical resection, and then we look at the path report and there's no mention of mediastinal nodes. That patient has not been adequately staged. We really do not know their surgical stage. We can surmise it. If they had a negative PET, a negative CAT scan pre-op, the likelihood of having mediastinal nodes are low, but it may completely alter how we treat these individuals. In 2013, at least in patients with N1 or N2 involvement, or stage 1 patients with tumors larger than 4 centimeters, the standard post-op is adjuvant platinum-based chemotherapy for 4 cycles. There is no proven role for a targeted agent in that setting. Certainly it's a research question. We clearly hope that one or more agents will emerge. Should we test these folks? Frankly, I think we should, because unfortunately, half or more will relapse, and I think it's very important to know their marker status for that day comes, and inevitably for many of these patients, that day will come. So we know whether they harbor an EGFR mutation, the disease comes back, particularly if it comes back in a site that's not readily biopsiable, you're ahead of the game. You know information that would otherwise take 2, 3, 4 weeks to process, plus the difficulty of trying to retrieve an older specimen, which might have been done in another hospital, and process that specimen. So from a practical standpoint, although it's not immediately actionable, I have asked our pathologists to perform reflex testing on surgical specimens with the knowledge that maybe it's not going to be used in the adjuvant setting, but it will be used subsequently.